All right, this is just kind of a visualization of the differences between the different types of arthritis. Okay, we've talked about, here's your normal joint. Okay, this is what you should have. Okay, you see the synovial fluid there. There's not too much, there's not too little. When you're dealing with osteoarthritis, remember osteoarthritis is non-inflammatory. Okay, it's not dealing with inflammation. Its problem is you've just kind of lost the fluid, and the grinding and mechanical breakdown of the joint results in loss of this cushion, the padding here. Okay, so it's kind of like taking, I don't know, if you've got like some mechanical instrument or something like that that doesn't have oil or doesn't have the lubricant that helps keep those things from rubbing and grinding. That's what osteoarthritis is. You've lost that lubricant and that ability to absorb shock. So therefore you have pain. Now on the other hand, rheumatoid arthritis, over to the right, is going to be an inflammatory disease. Okay, it's caused by inflammation. You have inflammation of the joint. So it's swollen, inflamed, and the synovial fluid, synovium, becomes inflamed. All right. You're going to have similar manifestations, because it's still a similar issue with joint pain and swelling. Well, swelling is usually going to occur with the rheumatoid. They can, yes, because they're pulling that inflammation, that swelling, that excess fluid off of the joint. Okay. All right. So this is, and I'll post this picture in the content section, but this is just kind of a breakdown, a general, I guess, comparison of the two different types of arthritis. All right. So let's go back real quick and just do a quick review. Who can tell me, or I guess just call them out, some of the manifestations of osteoarthritis? Pain, okay, good. Okay, sensitivity to temperature and humidity, absolutely. All right, when we're talking about pain, what are the what type of pain do we have? What's the nature of the pain? Okay, it changes as it progresses. Okay, so as the disease or the inflammation, or not osteoarthritis, it's not going to have the inflammation, but as the condition progresses, you're going to have changes in pain. What type of changes in pain will you see? Okay, early, you're going to have the pain come on during activity, and it's relieved when the patient takes a break. All right, but as we progress through the disease or the condition, they lose that relief. When they're doing an activity or whatever that causes the pain, early they stop and it gets better. Later on, it does not get better. Okay. All right. What else? What else are you going to see? Okay, nodules. All right, limited range of motion. Absolutely, and really with all of these symptoms, they're going to progress and get worse as the condition progresses. Okay, all right, what else? Okay, sensitivity to temperature, skeletal atrophy. Okay, difficulty with ADLs. Again, as they progress, it gets harder to do simple tasks. All right, any others? Okay, compression. Now, and it also depends on where the osteoarthritis is located too, right? Is osteoarthritis going to happen? Are you going to see it in every joint? Are you going to see it throughout the body? You could, but it's not going to be bilateral. It's not going to be systemically bilateral. I mean, it's not a systemic issue. It's going to be more due to overuse of specific joints, specific extremities. Okay. All right. On the other side, what about rheumatoid arthritis? It's bilateral. Okay. Bilateral. What else? Sorry. Fatigue, absolutely. And fatigue, you'll see fatigue with osteo as well. It's just not that general fatigue. Okay, the osteo, you see the fatigue because they're having to work a little harder or it hurts. Okay, they just get tired of working that extremity that's affected. Rheumatoid, you're going to have generalized fatigue, almost like flu. They just have these general muscle aches, fatigue, and it's really flu-like symptoms. So what else goes along with flu? Okay, weakness, weight loss. What else? There's a big one. It's a systemic inflammatory issue. Fever. There you go. Rheumatoid arthritis, commonly you will see fever. You know, when our immune system and our inflammatory response starts to occur, you know, our body reacts. You know, the immune system starts to respond, and along the lines there, we have fever as well. Now, it's not always. They're not going to have fever all the time. They're not going to have fever, just, you know, on a constant basis. But you will see that as the flare-ups occur, you will see some fever. All right. Any others with rheumatoid? Morning stiffness and joint deformity. And what did we say we needed to do, or I guess recommend for the rheumatoid arthritis patient to help with that morning stiffness? Moist heat. Okay, so what would be some good examples of moist heat? Okay, a warm or hot shower. What else? Warm compresses. Okay, directly to the joints that are really flaring up, the ones that are really affected. Okay, the warm shower is probably going to be your best bet though, because it knocks out all of them, right? But yeah, that's a very good educational point that you need to remember for those rheumatoid arthritis patients. All right, the key difference though, remember, osteo, unilateral, it's local. There's local injury or it's a local joint issue. Rheumatoid arthritis is going to be a systemic issue. Okay, you're going to see it in bilateral extremities. So if the knee is affected with rheumatoid arthritis, both knees are going to be affected. All right, and usually it's throughout the body. All right, so we're going to do a quick case study. Okay. All right, we've got a patient, and I kind of gave it away a little bit with arthritis being up there, but you're going to have to do a little bit more work than that. All right. So the patient comes to the clinic with symptoms of fatigue and hand wrist pain for 3 months. No, you don't have this one. I didn't want you to cheat and know all the answers before we got started. Patient reports that the fatigue has started to interfere with sleep, and NSAIDs have provided minimal pain relief. The nurse assesses that the proximal interphalangeal joint and also the metacarpophalangeal joints of both hands are warm, swollen, and painful to the touch with limited range of motion. Okay? So I know some of you are going to say, well, where are those joints? All right, well, here they are. Okay? This is the metacarpophalangeal, or phalangeal, and then here's the proximal interphalangeal joints. Okay, so these are the ones that are swollen. You've got the ones here, and then you've also got the middle ones here. Those are bilaterally swollen. All right, so there you go. My first question: what type of arthritis do we have? Rheumatoid arthritis. Okay. Of rheumatoid, yeah, you're going to have swelling, the inflammation, because it's inflammatory, so you're going to have that swelling. During the flare-ups, the inflammation gets worse. Okay. All right. So, what are the significant findings or the significant points that led you to believe that this is rheumatoid arthritis? Bilateral swelling. Okay. Any others? Okay, NSAIDs don't help. And, you know, the NSAIDs, whether they help or not, they may not be as effective with the osteo, but usually, initially, they're going to be effective with rheumatoid. Okay. All right. Any others? Interferes with sleep. Okay. And what is that going to tell you? Doesn't go away with rest. There you go. So now, what can we kind of assume? Well, we don't want to assume, but what, based off of that finding, what are we thinking may be going on? I mean, what's happened with this disease progression? It's later stage. Okay. It doesn't respond to rest. The NSAIDs, maybe they have worked in the past. We don't know. But at this point, we know that they're not working. That's what they're going to try first. All right. All right. So, what interventions would you suggest as a nurse, okay, that might help with this fatigue? Might help manage the patient's fatigue. Okay. Warm, moist heat in the morning. What else? Okay, make sure that they're taking their meds. Make sure that the med compliance is there on a nice routine, right? At the same time each day. All right, any others? There you go. Big time. Space out those activities. Add in rest periods, okay? You know, don't just do everything in the morning and then not be able to move for the rest of the day. Absolutely, okay? Sometimes those help as well, yeah. All right, so now let's see. Lab work is collected, and the results reveal you've got a positive rheumatoid factor, elevated ANA, and an ESR of 32. So what do these findings indicate? Okay, it kind of helps to confirm what we're already thinking, right? And you can have osteo in two joints. You know, you can have maybe both knees are hurting. Usually it's not quite as symmetrical, but this lab work is going to help to confirm that. All right. Just because we have a positive RF factor, that doesn't always mean that we have rheumatoid arthritis. But that means we have some type of inflammatory type issue. ESR, what's the ESR? Okay, SED rate, and that's going to really indicate inflammation of some kind. Now, again, that doesn't narrow down to just rheumatoid arthritis, but you couple that with the signs and symptoms, and that's kind of where they're going with that. Anybody know what the normal SED rate is? No? It's fine. Probably don't hear that a whole lot. 0 to 22 is what they usually go with. All right, 0 to 22. 32 would be pretty well elevated. Well, I'm sorry, I said 0 to 22. 0 to 22 for men, and then 0 to 29 for women. So females may have a little bit higher. But at this point, do we know if it's male or female? No. But 32 is going to be an elevation regardless, right? All right. Let's see what else we got. So, the patient is diagnosed with rheumatoid arthritis, and the healthcare provider prescribes a regimen of prednisone, 10 milligrams orally daily, methotrexate, 15 milligrams orally weekly, and then folate once per day. All right, now, this part of it, you need to know what these are, right? But this is, you're not prescribing. But what do you do? What do you need to know once the patient is ordered or prescribed these medications? What's your job as a nurse? Okay, I think I heard education. All right, you need to make sure that you educate the patient on the importance of compliance. Also, you need to educate them on what? Signs and symptoms, how to take it, when to take it, all that good stuff, right? All right, so what education would you provide for these medicines? Okay, report infection. All right, for which one? What's the one we really? The prednisone's a big one, because what is a steroid going to do? It's gonna reduce that immune function, right? That's what I mean. We're reducing inflammation. We want to reduce that inflammatory response, which is part of the immune system. All right. So any type of cold, cough, anything like that, we need to let the physician know pretty quick. All right, what else? What do we say about the methotrexate? Liver damage. Yeah. So what will we tell them related to liver damage? Don't drink alcohol. Absolutely. What else? What if they start, noticing any jaundice? Yellowing of the eyes is what you'll commonly see pretty quick. Any yellowish discoloration of the skin. Okay. Even just abdominal pain. All right. Well, it seems like we always have something else that comes up, and yeah, I don't even tell that story. It's just weird, so it's off topic. We'll move on. All right, so that's methotrexate. Okay, what else? What other kind of things do we need to look at? Well, folate, and I don't even know if we touched folate much before. Folate, we want to make sure that they eat foods rich in folic acid. Okay, so the vegetables, fruits, that sort of thing. Okay. All right, so now, what nursing diagnoses would you look at for this patient? What do you think you're going to kind of focus in on for our patient that now is diagnosed with rheumatoid arthritis? Okay, pain, safety. Those are two big ones right there, right? Pain and safety. All right, any others? Compliance, sure. Activity and tolerance, absolutely. Any others? What about some type of mental or psychological type thing? Any of those you might think of? Okay, start body image, sure. Immobility. So anxiety, immobility may even stem from, obviously, if they're having some knee issues or something like that, maybe they can't get around. So what could that cause them to not do? Not exercise, not even get out of the house, right? So they may have even some social isolation type issues. Alterations in just their daily life. All right, good. So, all right, so that's arthritis, rheumatoid arthritis specifically. Now we're going to move into the next thing, osteomyelitis. Osteomyelitis is an infection of the bone. It can be caused by either a direct or indirect invasion by an organism. Okay, so infection of the bone. All right, it can result from surgery, trauma, a number of things. Because what do we know about the bone? What happens with the bone? I mean, it's not just a stationary thing. It's there when you're born, and then it's just, you die with the same bone, right? What happens throughout the life cycle? The bone constantly changes. Okay, your entire skeletal system, it basically reforms, and old bone goes away. Calcium, from the that's been stored. That's where calcium's stored, right? That calcium leaves, new bone grows. So with that, what moves in and out? Okay, blood, because that's where blood is created, right? So you've got to just don't think of that bone as just a stationary structure that nothing comes in and out of. There's constantly stuff moving in and out of bone, including the potential for infection. Okay. All right. So some of the signs and symptoms. What do you think you would see for a patient or with a patient that's got an infection of the bone? Pain. Anytime you've got a skeletal issue, you got pain. Okay. It's a painful. All right. Inflammation, sure. Okay, fever, big time. All right, any others? One thing, it can be local or it can be systemic. Okay, it just depends on the infecting organism, how much it's spread, basically. All right, it can be widespread. It can also be systemic. Commonly, some of the most commonly affected bones are going to be the long bones. Also the spine. What common condition can lead to a spinal osteomyelitis? Meningitis, possibly, but what's something that we commonly treat, especially with our immobile patients? Decubitus ulcer. Okay, decubitus ulcer. A patient develops a sacral ulcer. What happens? They get that awful infection. We can't hardly treat it. We can't get it to go away. It's right there by the sacrum. You start getting sacral osteomyelitis. Okay, that's very, very common as well. So that's one of those that, especially if they're under our care, we can help prevent that, or at least, hopefully do some things that can prevent that from occurring. Now, a lot of times, especially in like that's more of the long-term setting, hospital setting. If patients in there in an acute setting, we can also do some things to help with that. Not quite as stringent there, but that's important. All right. So we've talked about fever. We've talked about pain. We've talked about inflammation. Any others? Fatigue. Sure. If we've got systemic effects of infection, we get tired, right? We have trouble with activity. All right. Any others? I know y'all just want me to give them to you, though. Blood issues? Yeah, osteomyelitis can definitely lead to, to systemic infection. There's kind of a lot of it. Can, okay. You can have bruising. You can have lots of stuff. All right. All right. So I'll give them to you. All right. Some of the local issues. You can have local severe bone pain, unrelieved by rest, worsened with activity, swelling, tenderness at the site, also warmth at the site, redness at the site, those signs of inflammation, and also restricted movement of the affected body part. All right, some of the systemic effects. You've got fever, night sweats or chills, restlessness, nausea, fatigue, and then the severe throbbing pain, but that's more local. All right. Now, if there's an open injury, if it's a result of maybe a fracture or some type of open fracture, you may see drainage. You may see pus-filled drainage, yellowish drainage that can occur as well. The infection may be bacterial, viral, or fungal. And staph is going to be your most common infecting organism. So medically, what do you think they're going to do to test or treat? Not test or treat, just do test right now. What are they going to do to treat or test it? Okay, they do cultures. They want to, do a culture and try to figure out what the issue is. What else? Now this is when it's draining and open. We're not going to open it up for no reason. But yeah, if it's open, we're going to try to test out some of that drainage and see what it looks like, or what it's got in it. All right, what else? Any others? What do we want to see? Okay, yeah. Lab values, definitely. You want to figure out, you know, it's pretty much going to confirm it a little bit. Or not confirm it, but at least give us an idea. Yeah, there's definitely infection there. What else? What do we want to see visually? There you go. We want to see what structures are involved. Okay, X-ray, CT, MRI, all those good things. All right. They want to see what all is infected, what all is affected, I guess, by the infection. You know, what's the scope? What's the you know, I guess the magnitude of the problem. All right. So treatment. If it's bacterial, antibiotics. You know, got to get some antibiotics going, and then a lot of it's going to be pain control, and then also control of the swelling. Now, commonly, there's not a fracture. Well, it could be a fracture along with it, but regardless of whether there's a fracture or not, they're usually going to immobilize. Okay, they're going to put a splint or some type of immobilizing device on the extremity, and a lot of this is preventative to prevent fracture. When you've got infection in a bone, it becomes very weak, and it's a lot more likely to have a fracture occur. So a lot of times they'll even almost prophylactically put a splint or a boot or whatever on it. And then also, now, you know, if the infection continues to get worse, they can go in and actually surgically debride, you know, drain, get all the infection out. Again, that's not necessarily the stuff you need to focus in on. You need to be aware of what that treatment is. All right. So here's what you would do. All right. Pain and fever management. Prevent further complications. All right. What complications can you think of could occur? You know, the fracture. Okay. You need to be careful with the extremity. If you're moving a patient that has osteomyelitis, you need to be aware of that. Okay, you don't need to jerk them around by their arms or their legs or whatever. You know, use your draw sheets. Be careful when you're positioning. All that good stuff. All right. Any other complications you can think of? It can spread. Okay. Yeah. So I mean, we want to. If it's a patient that has pretty good draining infection, they're probably going to be on contact precautions. Also, you know, if they've already got osteomyelitis, or they have regardless if they're immobile, we need to make sure we're doing the turning and coughing and deep breathing. We don't want to make anything worse. What's a big thing that we really check with all musculoskeletal and orthopedic type patients? Okay, range of motion. So we want to prevent contractures. Good. I wasn't even thinking of that one, but that's a really good one. All right. What else? Okay, DVTs. Sure. Okay, F&E. Absolutely. What specific? All right. If I've got a patient that has a broke arm, what am I checking? Pulses. I'm checking my neurovascular status. Okay, so the 6 Ps. That needs to be done with any extremity that has osteomyelitis. I mean, not just because it's, okay, well, we don't have a fracture, we don't have a cast. You need to check that stuff, okay? Make sure that there's not some type of inflammation causing a change in the circulation of that extremity. Because we really need circulation to that extremity to help with the healing process. Very, very important. All right. Initially, we want to minimize movement in affected area and elevate to reduce swelling. Avoid complications associated with immobility. Manage interdisciplinary care. So we need to work with our PT, our OT, all that good stuff. Okay, make sure that we're working in conjunction with them, laying out that day, you know, planning out the rest and activity periods, and then obviously administer antibiotics as ordered, and then monitor for complications associated with antibiotics. All right. Next, we're going to talk about hip fractures. I'm kind of surprised this is here. I thought that was somewhere else. We'll talk about hip fractures a little bit here. We got a whole section on fractures in probably a day or two. But hip fractures. you got two different types. Intracapsular hip fracture is a bone that's broken inside the joint. Okay? Intracapsular. It's inside the capsule of the joint. Skin traction is applied preoperatively to immobilize and prevent pain. You'll see some examples of that later on in the module. Treatment includes a total hip replacement or internal fixation with replacement of the femoral head with a prosthesis. Fixation. Does anybody know what fixation means? Just take a guess. Fixation, it fixes it in place. That's a good way to describe it. It's something that's done. You can do it internally or externally. We'll talk about that later. But to fixate, to make it stationary, to where it's in, in proper alignment. Yeah. In place. There you go. I'm sorry. Oh, they may do skin traction preoperatively. Commonly, they're going to do something to kind of immobilize and keep it from moving anymore. And then they'll do replacements. Either a total replacement, or they could do replacement of different pieces that are broken, basically. May do a femoral head, hardware, or something like that. We want to avoid hip flexion to help prevent displacement. Commonly, they'll put them in an abductor pillow. We don't want it to move out. We don't want it to move in. Think about the joint and what motion that it can take. Okay, if I'm immobilizing an arm, what joint, what movement do I have to restrict? It's one movement, right? A hip, there's a lot of different movements for a hip joint. So you have to immobilize all of those movements to prevent further damage. Okay. The abductor pillow keeps it from moving out, but keeps it from moving in. Adduction and abduction. All right. I'll do that. After surgery, they want it to kind of settle a little bit, I guess is a good way to describe it. Definitely before surgery to prevent damage, but after surgery they usually do that just to kind of allow it to start to heal. All right, so now we've got extracapsular. Extracapsular fracture can occur at the greater trochanter, or it can be intra-trochanteric fracture. Okay? It's outside of the actual joint itself. It can occur at the greater trochanter, or it can be intertrochanteric. INTERTROChanteric. Regardless, it's outside of the hip joint itself. That's a lot of that stuff. Just know there's two different types. You don't stress over that one too much. All right. I gotta go write a question about it. Huh? All right. The key preoperative treatment includes balanced suspension traction, which again we'll see that later. And a lot of this, I kind of meant to have a lot of this over in the fracture section, but we'll hit it now and hit it later too, I guess. Sorry. Yes, balanced skin traction. And I've got a nice suspension traction. You'll see a nice picture of it in the next set of slides. The key here, preoperatively, again, we want to immobilize the joint. We want to immobilize that movement. So your nursing care is not really going to change. You got a hip fracture, it doesn't matter where it's, what type it is. Okay, you can immobilize through skin traction, balance traction, whatever. That's not your call anyway, right? You just follow those orders, put the patient in traction where they're not going to be, the joint is not moving. All right. Surgical treatment, again, internal fixation. They'll do nail plates, screws, wires, all that good stuff. It's surgical. Okay. This is a look at some of the hardware that they will use. Okay. Basically, just a man-made joint. And this is what would go into a total hip replacement. This is kind of what it would look like following the replacement. All right, so your post-op care. And this is what you really need to hammer in. Yes, yeah, for both of them. It doesn't matter which one. You want to maintain the leg and hip in proper alignment. Okay, avoid flexion of the hips beyond 90 degrees. So basically, you don't want them to move their leg, their knee forward 90 degrees. So what's a common thing when that would occur? When they're getting up out of bed, when they're sitting. Okay, they don't need to sit down lower. Basically, their butt doesn't need to get lower than their knees. Okay, so when they sit down on the bed, make sure that the bed is elevated enough that they're not going to have to sit down too low. Okay, 90 degrees. It can cause that hip pop back out of place. We don't want that either. More than anything, it's going to hurt them because they're going to let you know that it's not a fun thing to do. So, raised toilet seats, reclining chairs that have, a high enough seat. Be sure to teach the patient to also avoid twisting of the body or crossing of the legs. Most patients that are undergoing a hip replacement, they need to be educated not to cross their legs anyway. We want to prevent DVTs, which is another thing you need to watch for with the hip replacement too, right? It's an immobilized or at least a reduced mobility patient. So prepare for that. Let's see. Turn the client from the back to the unaffected side. So immediately post-op, you're turning. You don't want to turn them onto that joint. You turn them onto the non-affected joint. The abductor pillow, it prevents joint rotation. You're in bad shape. If you've got bilateral fracture, you at least need to make sure that they are positioned, change weight distribution, on the back, on the back side. And that kind of goes, because you'll have traction patients, skeletal traction patients. They can't really, you can't just go in and move them that much. They at least need to be reminded to shift their weight. Usually, if it's going to be that type of patient, they're going to put them on a low flow mattress or something like that, with the airflow, that can change that weight distribution. And you'll get that. Usually that's a trauma patient. Hopefully not an older trauma patient that's going to be at even more risk, but you will. All right. You also want to elevate the head of the bed only for meals, 30 to 45 degrees. We don't want to sit them up 90 degrees, right? Nice, easy elevation, just to make sure they don't choke. They're going to let you know to stop. They're not going to let you just keep raising them up. They're going to let you know. And then you've also got incision care. Okay, you got to monitor the incision. These hip replacements are bad about getting infection. Okay, so you really have to do good, stringent nursing care to prevent that infection from occurring. Commonly, they'll have drains. Maintain the hemovacs. TLS, Voltaren, whatever type of drain they have. Make sure you maintain that. Keep it compressed, where it's pulling off the drainage. And also anti-embolism stockings, so to help prevent the DVTs. Your normal DVT stuff. Make sure that you follow those protocols. Patients, they may have even had to stop some of their blood thinners before the surgery. they'll usually try to get those back going again as much as they can, but that puts them at even greater risk of the DVTs. All right. Physical therapy is going to start pretty quick. They're going to be gradual with the movements and all that, the range of motion. But again, that's going to be prescribed by the physician. All right, knee replacement. Knee replacement. Basically, they implant a device to substitute for the femoral condyles and the tibial joint surfaces. Replace the surfaces, basically. Yeah. It's not real complicated there. Take out the old knee joint and put a new one in. The key you need to know is post-op. All right, post-op care. And it's going to be fairly similar to the hip, just with a different joint. I'm going to monitor the incision for drainage and infection. Maintain any drains in the vacs, whatever, that are in place. All right. With this one, they're going to usually start passive range of motion exercises pretty quick. Okay, 24 to 48 hours. Usually for 24 to 48 hours after the surgery. They'll do the CPM machines. I don't know if y'all seen those. It's continuous passive motion devices. Basically, put their leg on a motor that passively moves their leg in and out. Okay. Helps build the joint back up and also works the joint. And they're not, it's passive. Okay, so they're just relaxing as much as they possibly can, and it helps with that. Now, usually there's some kind of regimen. There's a schedule. They'll have it on for however many hours, and then they'll take it off. All of that's physician ordered, so you don't have to worry about that. Commonly they're going to need medicines before those regimens. That regimen starts. So make sure that they, have their pain controlled. All right. Also, activity is going to be, again, ordered, but usually they're going to have alterations in the activity level. It's going to be some type of non-weight bearing or touchdown weight bearing of some type. It's going to be some alteration in the weight bearing to that extremity, at least for a short period of time. And here's just a look at the knee prosthesis. All right, next we've got carpal tunnel syndrome. This is a common condition in which the median nerve is compressed at the wrist, and it results in numbness and pain. It's caused by the pressure. The key is those that are at most risk are those that are doing some type of repetitive motion, typing, y'all that are taking notes a lot, and that sort of thing. The signs and symptoms are going to include pain, numbness in the palmar side of the fingers, and weakness of the thumb. Okay. So pain and weakness to the thumb side. All right. Some of the treatment options, they'll do splinting to prevent flexion, hyperextension, steroid injections. They can also do. Just depends on the severity. And then rest. That's the big thing. Here's just some other images. It's talking about basically the compression here of the medial nerve. If all of the non-invasive or non-surgical methods don't work, then they can go in and do a surgical carpal tunnel release. And they basically just release that ligament. Post-op, this is your key. Pain medicine or pain management, rehab, assess the neurovascular status. Okay, make sure they have sensation. Make sure they have circulation. With orthopedics, if they went into the surgery with that function, you want them to come out of the surgery without a function, regardless of what it is. Okay? So we don't want sensation changes. We don't want, obviously movement can be affected by pain, but as long as it's just because it's affected by pain. We want them to be able to perform the same activities that they went into. All right. Some of our spinal problems. First, we've got a herniated disc. Herniated disc is a herniation of the intravertebral disc into the spinal column. And here's what you see here. It compresses on the nerve, and that's what causes the pain. All right, there's different types of procedures that they'll do. It just depends on where the issue is occurring. They can do spinal fusions, also laminectomies. Laminectomy is when they take the bony roof of the spinal canal and they remove part of the lamina, and it decompresses that pinch on the nerve, basically, okay, or the herniation on the nerve. It can be done on any part of the spinal cord and release pressure on the spinal roots. Now, the spinal fusions, there's a number of things that they can do or use for the spinal fusions. Your scoliosis patients, y'all probably touched on this in peds. These scoliosis patients that you see, that spinal fusion. We talked a little bit about that in clinical last week. It's a rough surgery. They're basically going in and fusing portions of the spine using their own, their own spackle is almost like what we talked about it with. But they take, Google it, and you can see a video. But you can watch a video of a spinal fusion actually being done. It's a very, very in-depth, invasive surgery. They take hardware and they place it on each of the vertebral structures up through the spinal canal. Okay. They put those in place and then put rods through that hardware, and that straightens out the spine. Okay. If it's done for a herniation, it's a little bit different. You've got a couple vertebrae that are affected. So it's a much smaller procedure, I guess. There's just not as much affected. These scoliosis kids that have the spinal fusion done, they basically cut them from the top, bottom of the neck all the way down to the sacrum, and they are straightening out the entire length of the spine. We had one of our nurses that went and watched one, and we had been taking care of, I bet I took care of 200 or 300 spinal fusion kids, but she went and watched the procedure. She said they went in with bolt cutters. They clipped all the bony prominences going down through there, put that over in a blender, and they had already obtained blood from the patient prior to the procedure. They put that blood and the bone into the blender, they spin it up, and it makes like a paste almost. Then they take that paste, and as they spread that paste along where they put the rods, that's what actually fuses the vertebrae together. Okay. It's pretty, for me, I've been taking care of these kids, and that's a tough surgery. Nobody disputed that, but you can actually kind of understand, okay, these people are in pain, and there's a reason, that's why. One of the nurses asked one of the physicians one day, they said, would you ever take out the rod, or the rods themselves? But no, not unless there's an infection or something that causes us to want to remove it. And they said, well, would you have to put a new rod in place? They said, no. Once you've done that fusion, the bone and that material fuses together, and he said it's harder than any steel rod we could put in. he said, you know, that part at that point is much stronger than that rod that's in place anyway. It's pretty cool. Sometimes, you know, and I know we go through a lot of this stuff that's not necessarily that necessary from a test standpoint, right? But just to understand what's going on with the procedure so that you know how to take care of that patient post-op is important. You know, you don't have to know the ins and outs of these procedures. You know, that's not your job. But you do need to kind of be aware and have some perspective on what, you know, what they're going through post-op. All right, so our post-op care, if that leaves that in, our post-op care for any type of spinal surgery. There are important things you need to monitor for. Big thing is prevent and also assess for complications. What are some of the complications we really need to look for? Infection. What else? Neurological, absolutely. What type of neurological? What specifically are we looking at? Okay, exactly. We're looking for movement and sensation. Okay, again, if they went into the surgery with that function, they need to come out with that function. Took care of a spinal fusion patient, and it was a 16, 17-year-old boy, male, and he came out and he couldn't void. Okay, which is another thing you have to make sure you assess for. You've got to make sure you assess for the void. But he couldn't void, which is not that uncommon. They come out, you know, they kind of wake up, everything's getting shut down during the surgery. They can't void post-op. Okay, we put a Foley in, take it out 8 hours later, and they void like crazy. Okay, no problem. This guy, we kept putting the Foley in and taking it out, and he never was able to void. So 4 or 5 days out, he still can't void. We had to send him home doing in and out casts. So we had to teach him how to do in and out casts. And you know, you can think about, okay, a teenage guy, that's pretty traumatizing. You know, not only is he having to learn this new thing that's not very comfortable, not, you know, painful, it's embarrassing for him and all that. Luckily, about a month later, he was able to regain that ability. I don't even know what did it, but it could have just been, hey, they hit something, they hit a nerve during the procedure, didn't necessarily cut it, didn't do any damage, but maybe caused some swelling, or, you know, caused something to compress it a little bit, and that swelling had to go down. But regardless, you've got to monitor for that. If you've got a patient 8 hours, 10 hours post-op, and they haven't voided, you better be on the phone with the physician, because it could be something a little bit more than just, hey, you can't do it. Okay? It could even be a urethral problem. Maybe they, when they put the Foley in, pre-op or intra-op, something kind of caused some swelling or some kinking. You know, you just have to make sure you monitor for that post-op. Pain control is obviously going to be a big one. Commonly, they'll come back with PCAs or, regardless, some type of narcotic, opioid, but usually some type of PCA is what they'll initially come back with. Wound care is a big one. We talked about infection. You want to monitor the incision site for infection. Also monitor for drainage, which you would expect drainage. I mean, this is a really, really in-depth invasive procedure. You're going to have some drainage. Now, profuse bleeding, that's not a good thing. It may be that they have to come in and repair an incision, something like that. Another big thing is going to be actual wound or incision care as far as dressings. Okay, there's a number of different types of dressings that they'll use. Sometimes they'll use Dermabond, sometimes they'll use Primapore, bulky ABD dressings. You know, a number of different things they could do. That usually kind of comes down to the physician preference. But you have to monitor for that excess drainage. All right, CSF check. Why are we checking for CSF? Yeah, I mean, you're right there. It would be really easy to hit something they're not supposed to hit, or cause some type of leak. So you want to check for that. And how do we check for CSF, especially in that case? Okay, you can do the strips. What's going to be probably your biggest indicator, or I guess first indicator? Okay, well, a headache. All right, but when you look at that dressing, you're going to see the little halos around the bloody drainage. Okay, you'll see that. Look for that. When you take off an old dressing, look for it. And then if you miss that, the headaches, that's usually where you'll see a lot of it. Patient positioning and mobility, they usually try to get them up pretty quick. Even with the invasive, full body, not full body, but the full spinal fusion. Second day post-op, at the very latest, they're getting them up to a chair. They're moving them in some way. Because if not, they'll sit there and they'll lay there all day and never want to get up. Sometimes you have to kind of be a little firm with them and make sure that they get up. Usually the third day they're getting them up walking down the hall. At least third day by the latest, very latest. All right, and then discharge teaching. What do you think we would include in our discharge teaching? Okay, infection. Yeah, no contact. Yeah, they're not going to be the ones that are able to go back and play football right away. They're probably going to say, no, we need to hold off for a while. I've seen a lot of kids come back with, we had one that, a month, 2 months out, decide they're going to a theme park and ride a roller coaster. Well, hardware came through the skin. They're going to have a whole packet. They're going to have a whole list of things they can't do. They need to be careful. Any type of fall. We had a kid that fell 2 steps, just kind of slipped and fell on the steps and came down on his backside. Yeah, had to do new hardware. I don't know what his was. Some type of revision. It's pretty invasive stuff. But they can't do anything overly active or, with a lot of contact. That's the key. You're going to have somewhat limited range of motion, for forever at that point, because it's fused. There is, as far as bending, there is going to be some change to the ability to bend and flexibility of the spine. I mean, it's not a long time. They will probably go for a couple weeks or so, potentially. It just kind of depends on how well they're doing and how well they're moving post-op. We had some that would get up and they're running, not running, but you can't even keep them down. Usually those are the girls. The guys were the weenies with it. They just, they fussed, they whined, they cried. It was. I'll admit it, because it was obvious. And it was obvious those guys just couldn't handle it. But anyway, so yeah, it just kind of depends on the situation. But if they do have physical therapy ordered, make sure that we educate. At least make sure you go to your appointments. Make sure you go. A lot of the time, and we'll kind of touch this a little more in traction. We would have traction set up just to get them in a position where they could do a fusion. They would do the halo traction, where they've got a halo device in place, and then we would hang weights from the halo. These were patients that were just really, really, the curvature was to the point they were really affected. It was really affecting their ability to breathe. Physically, there was a lot of physical deformations. One of the physicians we had actually took a box. He built a box and brought it up there. And it was about this high and had 2 grooves in it. And we took the bed, just a regular hospital bed, and picked it up and put the head of the bed up on the box. And what that did was that allowed us to do an angle, a much greater angle, to put them in traction. So they're basically hanging by the top of this halo, not completely vertical, but pretty dang close. but that was designed just to open them up enough to be able to do spinal fusion procedure. And I know I'm getting way off, but you know, there's a lot of stuff that they'll do, and a lot of it, especially with orthopedics, it's very mechanical. They've got different ways that they can put, you know, these bones and these structures in different positions. All right, so disc-related problems we've talked about. This probably should have been first, but we've got a herniated disc. You can also have degeneration of the disc. Basically, again, the padding or the cushion between the vertebrae can wear thin. Similar to osteoarthritis, it's more of that type of an issue. And when you lose that cushion, bone hitting bone, it's not a good thing. I mean, it causes problems and pain and all that. So these are some of the issues. This is an example of what it should look like, the normal disc. There's the degenerated disc. We've got a bulging disc, and then finally you got the herniation where it actually ruptures through. Thinning of the disc, and then here's another example of the degeneration. We've talked about this. We're not going to do this a lot, but this is a look at the herniated disc repair. And then spinal fusion, we talked a lot about there. Okay, this is something we didn't touch. Where the incisions are going to occur. A posterior cervical incision, and again, it depends on the degree or the amount of fusion they need to do. But here's a cervical incision, anterior cervical incision. Commonly, what you think of when you think of a spinal fusion is going to be posterior. That's what you typically have as a patient. Anterior, you may see anterior as well. We had some anterior. They didn't do those quite as often. Usually those are in really, really bad shape. Basically, they're going in from the side, and they're having to do anterior work on the spine as well. Usually those patients would end up with a chest tube because there's going to be some deflation of the lung. They had to re-expand back out. All right, and then again, this is the anterior aspect of the lumbar incision. So again, they're going into the pleural cavity. You got to have a chest tube following to re-expand. And then here's the posterior lumbar incision. The scoliosis kids, they're basically all connected. You start at the top and you work all the way down to the sacrum. All right. Again, these are just kind of images that you can look at. They're basically what I described for the most part. It deals with the bone grafting and all that. All right, next we've got a laminectomy. And we talked about this, but basically where you remove all or part of the posterior arch of the vertebrae. It may be done to alleviate compression on the cord or spinal nerves. If there's swelling that's compressing on a spinal nerve, reduction of that swelling is basically what they're doing there. Again, these are procedures you don't have to know the ins and outs of. You just have to be aware of. All right, now we've got gout. All right, gout. It's a systemic disease in which urate crystals deposit into the joints and other body tissues. It leads to abnormal amounts of uric acid in the body. And there's two different types. There's primary gout, which results from a disorder of purine metabolism. The exact cause is unknown, but usually the risks are increased with hyperuricemia. And what do you think hyperuricemia is? It's based off of the word. Too much uric acid in the blood, right? All right. This is a result or related to excess rate of uric acid production or a decreased rate of uric acid excretion by the kidneys. So patients that have renal failure, kidney issues, they can develop gout because their kidneys can't pull off enough of the uric acid. That would be more of a secondary. Well, it would be secondary. The renal failure caused the gout. All right. Other risk factors for gout include obesity and alcohol consumption. All right. It's usually seen in men 40 to 50 years of age. All right. Secondary gout is uric acid increases related to another disease process. So that's what we talked about, kidney failure. Reduces the ability to excrete or remove the uric acid. So that's when they develop the gout. Okay, some of the, let's go into this. There's different phases of gout, okay, the gouty joint. First, you've got the asymptomatic phase, where there's no symptoms, you just have increased uric acid levels, okay. At this point, they haven't diagnosed gout. It's just an elevation in uric acid. It's an indicator that the patient may be developing gout. The acute phase, patient suffers from excruciating pain and inflammation of one or more small joints, especially the great toe. That's when you're really going to see gout is almost always seen in that great toe. Excruciating, are you aware of the excruciating aspect of that pain? All right, the intermittent phase, it's asymptomatic periods between acute attacks. Okay, so they have the acute attack, everything settles down for a while, and then it'll come back. Now, with repeated exacerbations, chronic gout can develop. It results from repeated episodes of acute gout and results in deposits of urate crystals under the skin and within the major organs, especially the renal system. All right, and this is a look at some severe gout, okay? Very severe gout. This is obviously not affecting the great toe here, but I'm sure if you looked at the great toe, there's going to be some very severe symptoms. All right, some of the assessment findings, okay? Obviously the pain in the involved joints. They say they've got a lot of foot pain, specifically the great toe. That's a really good indicator. Also swelling and inflammation of the joints. Low-grade fever, again, may develop. It's inflammation, so you may have an inflammatory response. Malaise and headache. Pruritus. M-A-L-A-I-S-E. I mean, I think we're talking about the same word there. Okay, yes, not like anger, not like malice and anger. But yeah. All right. Also, presence of renal stones, and as we talked about, elevated uric acid levels. All right, so what do we do for these individuals that have gout? Well, low purine diet. Okay. Purines are going to be your organ meats, anchovies, a lot of times seafood, usually like sardines and stuff like that. I've got high uric acid levels of purines. So, beans, I think beans are high in purine. think pork's got a lot of. That's all he can have. Huh? Yeah. Yeah, that's one of the precursors for a lot of stuff we talk about, isn't it? All right. Also, wines and aged cheeses are high in the purines. We do want to encourage high fluid intake, so those fluids that are non-alcoholic, but high fluid intake, specifically water, because we want to prevent stone formation or calculi. Encourage weight reduction if required. Also avoid alcohol, starvation diets, because they may precipitate a gout attack. Yeah, like not eating at all. Yeah. Yeah, you gotta eat something, but make sure it's the right stuff. Chicken and water. All right. We want to increase the pH, urinary pH, above 6 by eating alkaline or alkalinic foods, such as citrus fruits, juices, milk, and other dairy products. Provide bed rest during the acute attacks. Monitor joint range of motion and the ability and appearance of the joints. Position the joint in a mild flexing position during an acute attack. Elevate the affected extremity, and protect the joint or affected joint from excess movement and direct contact with sheets or blankets. One of the ways we can do that is with a bed cradle. So if you've got a particular extremity that's really involved, so a lot of times they'll put it at the foot of the bed if it's a toe or feet that are really causing a problem. It just removes that, that contact and the pressure. Even that light pressure is enough to set it off or make it worse. I'm not sure why it would be. It's probably just a. It's more of a comfort thing, I guess. I don't know. I'm not sure why it helps. But yeah, I guess it seems to help. I don't know if it helps to kind of remove some of those. I'm just guessing. Also, provide heat or cold for local treatments to the affected joints as prescribed. And then NSAIDs and other anti-gout medications are going to be prescribed as well. Some of these anti-gout agents, well, it depends on the type. Acute medications are going to obviously be for acute exacerbations. Colchicine is a drug that's used to help prevent the attacks and also treat the initial symptoms. So it can kind of help with both. Usually it's more of an acute type medication though. And they will commonly give this in combination with NSAIDs. The NSAIDs are going to help to reduce that inflammatory response as well. Corticosteroids also may be used, again, for the inflammation. Some of the chronic maintenance medications include xanthine oxidase inhibitors, such as allopurinol, probably going to be your most common. Allopurinol, and then also the Uloric. They limit uric acid production, and we also want to monitor closely for liver failure for these patients. All right, some of the signs of toxicity for the xanthine oxidase inhibitors, so allopurinol. You're going to monitor for a maculopapular rash, maculopapular rash, also fever, chills, and joint pain. And then some of the rare side effects include bone marrow depression, nausea, and diarrhea. You need to be familiar with those. You just need to be familiar with medication and some of the things to monitor for. Maculopapular rash, fever, chills, joint pain, and then rarely bone marrow depression, nausea, and diarrhea. Yes, that's the xanthine oxidase inhibitor specifically. All right, and then another type of the chronic medications include the uric acid removal agents. So the xanthines, they limit production, and then the uric acid removal agents obviously are going to get rid of it, get rid of the uric acid that's there. Benamid is probably one of your most common. With these agents, you want to encourage fluid intake, which you should be doing anyway with gout, but really stress increased fluid intake. And then with this one, monitor kidney function. Okay. So the uric acid removal agents, remember the kidneys are going to remove the uric acid, so you got to watch for kidney damage with these. And also avoid alcohol. It's going to make it worse. But you need to avoid alcohol anyway. And I would say avoid alcohol with all of these medications because you've either got liver damage or you got kidney problems. So just no alcohol. Gout equals no alcohol. Only chicken and water. All right, got a question? All alcohol. All of it. Nope. Because we also have wines and aged cheeses as well. So all alcohol. I have no idea on that one. I know for this, gout, no alcohol. Okay. Well, you need to know if you see the signs, well, you're going to report it. And also in your education, you need to be able to educate the patients on if you see these signs, let your physician or let your provider know. Because they're probably going to stop the medication or alter it or at least look at it. Because if it's a toxic thing, rather than just a side effect, if it's a toxic issue, they're going to reduce the dose. Or probably take them off of it for just a little while. Alright, so no alcohol. Liver damage on the xanthines, uric acid, the removal agents, you're going to watch for kidney damage. And remember those signs of toxicity on the xanthines. Another thing, and I didn't mention this, on the uric acid removal agents. One of the other big issues, again, we've talked about, or at least I mentioned it a while ago, the renal calculi, okay, the kidney stones. Okay? It's a big thing that they can kind of develop. That's why we stress the fluid intake. So, encourage fluids. Also, the uric acid removal agents, you want to make sure that, they can cause drowsiness at times. So you want to be aware of that, safety precautions along with that. And here's another big one. One of the problems they have is with compliance. Sometimes it takes days to weeks before they start really improving things. Okay. Anytime you have a medication where it can cause, it has a delayed, delayed efficacy or whatever you want to describe it as, patients just don't want to do it. They don't want to take them. They decide, hey, this isn't working, this isn't helping, so we're just going to stop taking it. So make sure you encourage compliance and warn them ahead of time. Let them know before, hey, look, you're not going to see this overnight. you know, you're not going to see these changes overnight. It takes a little while. Yeah, it's going to be the therapeutic effects. Yeah. Okay.
Oh man, if I do the crazy or something.
Yeah. Yeah, the therapeutic effects that you'll see. All right. Okay. So that's got our anti-gout agents. You need to be aware of those and kind of what you need to do with that. Next, we got Lyme disease. Okay. When do you get Lyme disease? After a tick bite. Okay. This is a reportable systemic infectious disease that results from a tick bite. It is contagious. Okay. Stage 1 is going to be the localized, localized phase. The patient presents with flu-like symptoms, erythema migrans, or round or oval, flat, or slightly raised rash. Okay. You need to know that sign. Also, pain and stiffness in the muscles and the joints. So these patients come in with arthritic, flu-like symptoms. Okay. Can we what? Yeah. Yeah. Well, I think that's not one of them making you fill in, is it? Okay. All right, we'll go back. I'll go back. So, whoa. All right. So, I'll whoa a little bit. Yeah, look, let me know. I don't mind slowing down, I promise you. I get going, and, you know, I blow through these slides pretty quick. I don't know. Some of you want me to go faster so we can finish up, but I'll slow down some. All right. So, you get a tick bite. Causes a systemic infectious disease. Stage 1 is localized. You'll see flu-like symptoms. And erythema migrans. Did I say that one right? I don't know if I did or not. I mean, we'll go with it. But those are the round or oval, flat, or slightly raised rash, okay, that develops. And pain and stiffness in the muscles and joints. Okay. So they feel like they have a mix between flu and arthritis, and then they got this crazy rash going on, and they just don't know what's going on. Okay. And usually Lyme disease is one of those that they just kind of test for. If they don't test for it, then they don't really think about it. You know, I don't know. It's kind of one of those weird things that they'll test when they don't really know what's going on. Because it's important to diagnose early, I guess is the key there. Most patients in the U.S. tend to only have one lesion, sometimes referred to as a bullseye lesion. Okay, so they've got this oval, flat, slightly raised rash with one lesion. It typically lasts around 2 to 12 weeks after the tick bite. All right, and treatment's going to be with oral antibiotics. Ampicillin, doxycycline, erythromycin. So if they catch it early, it's fairly treatable. I mean, it's easily treated in most cases. Now, if they don't catch it early, it moves into the stage 2 or early dissemination phase. Carditis, dysrhythmias, dyspnea, palpitations, dizziness, meningitis, and also facial paralysis can develop, and also peripheral neuritis. You start having a lot of systems start to become involved. You know, everything from cardiac, respiratory, and then also neurological. at this point, now they're really freaking out because the patient doesn't know what's going on. If they've made it to this phase and they have not been diagnosed, once they make it to this phase, IV antibiotics are going to be required. Extended IV therapy usually for 30 plus days. But typically they're going to go home with antibiotics once they kind of get out of that more critical phase. All right, and if we still don't get it knocked out at this point, and it moves into stage 3, which is chronic persistent. What does chronic persistent mean? It stays around, right? It's not going away. So it can become a chronic issue that they go through the rest of their life, or at least for a long, extended period of time. Chronic complications can result from delayed treatment, which include arthritis, chronic fatigue, and cognitive deficits. And these symptoms can develop months to years after the tick bite and can be permanent. So it may be that they treat, they think they've got it knocked out, and then they come back later on. So that's the issue there. Yeah, I don't know all the specifics. I know there's all kinds of stuff that, and I think a lot of it they kind of contribute back to the Lyme disease, and a lot of it probably warranted. Some of it I don't know. But yeah, you'll hear, well, patient will come in with something crazy and I'll say, yeah, I had Lyme disease 5 years ago. Okay, well, it may be related, it may not. So. Yeah, they're going to test for it. It's a lab test that they can do. I'm not sure what the actual lab is, but yeah, there is a lab test that they'll do, and it shows up as they've got Lyme disease. I don't know. I'm not sure if there's some type of titer or something. I don't know. Yeah. All right. So now we've got osteomalacia. Osteomalacia is an uncommon metabolic disease characterized by inadequate and delayed mineralization that results in compact and spongy bone. Basically, the bone kind of turns to mush a little bit. It's just not as strong and dense as it should be. Mineral calcification and deposits it just doesn't occur. Okay, so the calcium deposits aren't there, and then the bone regrowth or bone generation does not occur like it should. The replaced bone consists of soft material rather than rigid bone. All right, in adults, it's osteomalacia. They also often refer to it as rickets in children. But it's a lot more. It's more rare in the U.S. and Europe, Western Europe anyway. All right, the most common signs and symptoms that you'll see include persistent skeletal pain, recurring fractures, lower back pain, progressive muscle weakness, weight loss, and anorexia. And as it continues to progress, you'll see changes to the bone structure, okay? Deformities of the bone, kyphosis, that sort of thing. You'll start seeing these deformities to develop. Yeah. Skeletal pain. especially when weight bearing. Low back pain, progressive muscular weakness, weight loss, anorexia, and then bone deformities and fractures. I mentioned that one. Recurrent fractures. All right, the diagnosis. You're going to see decreased calcium or phosphorus levels, and also elevated serum alkaline phosphatase. All right. Reduced serum calcium levels or reduced phosphorus levels. There's just going to be an imbalance there. There's going to be reductions there. Also, elevated serum alkaline phosphatase. And the big one's going to be the X-ray. X-ray is going to show generalized bone demineralization. So lack of density in the bone. All right, treatments are going to be aimed at treating the underlying cause, calcium supplements, vitamin D supplements, also dietary changes. And that's really the big thing. It's not like they can give some medicine and knock it out. It's going to be a process of calcium restoration. Alright, so that's got that one. Oh. Well, basically going to be... Well, you tell me. What are we going to do? What are we going to do with that patient? Okay, educate. Pain control, okay. If they have fractures and things like that. But what's the big thing you think we'll do? Safety. Safety. Yeah, I should have said that. Safety. All right. Administer medications, the diet, and all that kind of stuff. Encourage calcium intake. Encourage the vitamin D supplements. But yeah, safety is going to be your big thing there.